All right, guys, we are going to be working through our nutrition presentation today. This is going to be fairly short and sweet. So when we are thinking about nutrition in terms of analyzing cues, weight is one of the primary ways we are going to monitor a patient's nutritional status. Their weight is either stable, so they are able to maintain a healthy weight, or it is unstable. They're unable to maintain it. It could be too much weight, so this would be our obesity patients, or not enough, our anorexia nervosa or bulimia nervosa patients. We also have to think about how patients can ingest nutrition. This can either be enteral, so through the gut, or parenteral. This bypasses the gut entirely, so IV routes, which we'll talk about more. Dysphagia is also going to be patients who have difficulty swallowing. And then we also have aspiration. This is patients where their food and nutrition is going where it shouldn't go, the lungs. There's an easy way to tell if your patient is aspirating. Give them something to drink and then ask them to speak. If their speech sounds wet, they are likely a silent aspirator, because some people aspirate silently and we're not able to tell that that's actually something that's going on for them. But it is still going into their lungs rather than into their esophagus. We also have a couple of different aspects that we need to consider. Can always think of the stoma. A lot of people think of stoma as a wound, but a stoma is really just an opening. So the mouth is a stoma. If we have stomatitis, so that's inflammation of a stoma, it could be in their mouth, but it could also be in their throat or in the lining of their GI tract. There's lots of areas for stomatitis to actually present. These patients are going to be very reluctant to eat because their mouth hurts or their throat hurts or the esophagus hurts, and it's physically painful for them to be eating. So we need to make sure we're monitoring their nutritional status as well. As far as age is concerned, up until 4 months of age, infants should be strictly breastfed or formula fed. If they are on formula, we want to make sure that they are mixing the formula properly and not diluting it too far. If they are diluting it too far, the child would not be getting adequate calories. They won't be getting adequate nutrition, and then they will be at risk for malnutrition. We are going to start solid foods for infants between 4 and 6 months of age. We want to start with very simple things and add in slowly, add one food at a time. They're going to be separated by a week each so that we can detect the presence of allergies. We also want to make sure that we are giving foods that are appropriate for their safety, so for their airway safety, really. The main things that we're concerned about are things that are small and round and can fit perfectly in a child-sized airway. So grapes and hot dogs are classic examples of this. We want to make sure that if they are eating grapes or hot dogs, we're actually cutting them up so that it's not a choking hazard. Then we have our toddler age. These have traditionally very picky eaters, are toddlers, but we have to consider whether or not it is something that they want to eat versus something that they need to eat, because those are separate. We still need to make sure that the child is getting the correct number of nutrients each day, the correct amount of nutrients each day, and getting healthy food choices. One of the tricks is just to present the things over and over again so that they are still being introduced to those food things. Then we have our school-age children. We're starting to see significantly increased obesity rates in school-age children across the United States, which is leading to increased diabetes, increased liver cirrhosis in children. We're seeing gallstones, et cetera, as a result of these unhealthy food relationships with young people. Okay, apparently that cut out, and I'm not entirely sure why, but we are going to go ahead and continue on. So we're talking about nutrition. We were discussing the poverty and young people eating disorders. So sometimes with eating disorders in young people, this is a way for them to control something in their environment. A lot of times they feel a lot of pressure and stress from just the teenage things that go on in the stressors that are in their lives, and they want something to control, and eating and food patterns are something that they're able to control. This can definitely lead to some eating disorders. We also want to consider cultural considerations whenever we're doing a nutritional assessment. If you have a patient who's in the hospital and they're not eating the hospital foods, it's possible that they just have some different foods from their cultural background, and the hospital foods aren't anything that they're interested in eating. Think about what your personal, comfort food is, and then imagine not being able to have access to that. Like if you have a Pakistani patient who doesn't have any access to their personal comfort foods or cultural comfort foods, they just might not be interested in eating the foods that are available to them. Socioeconomics is a massive predictor of malnutrition just across the board, not just in the childhood population, is one of the main risk factors for malnutrition. Alcohol consideration needs to be taken into account as well. It is entirely possible to consume your daily caloric intake in alcohol alone and still be malnourished. Your patient may have an appropriate weight or even be overweight, but still be severely malnourished because they're getting enough calories, but they aren't getting enough nutrients. Whenever we are considering nutrition, we definitely want to consider some lab data as well. Protein, albumin, and prealbumin are some major predictors of nutritional status. We can monitor those lab values, make sure that they are adequate to ensure that our patient is properly nourished, as well as these other CMP and BMP that you see on these slides. We are going to get a little bit more into those specifics when we talk about the fluid and electrolyte lecture as well as the wound care lecture, but make sure you do know these normal lab values. H&H we would also want to consider when we are looking at nutritional status for a patient. BMI, I don't really need you to know the categories. I do want you to know that BMI is an aspect of our objective data when we are considering nutrition, because it's height and weight, right? We know that. All right, so when you're thinking about nursing diagnoses, go through your NANDA, see if you can come up with some nursing diagnoses that would follow this. Inadequate nutritional requirements is one of the primary ones. It can be over or under, but I want you to go through and see what else you can identify. For nutritional, as far as diets, we don't care about fad diets in nursing. We care about diets that are medical in nature. So texture modification is a major way to do this. We can use this for people who need gut rest or who have just had surgery, people who have difficulty swallowing. There's lots of reasons we might see these ordered. An example, we're always going to progress this from least aggressive to most aggressive. So we're going to start off with clear liquids. These are things you can see through. So this can be Jell-O, this can be coffee, because if you hold it up to light, you can still see the difference between light and dark. This is ginger ale, water. All of these are going to be examples of clear liquids. Then we're going to progress the patient to full liquid. This is going to be things that are liquid at room temperature. So ice cream counts, orange juice, because it has lots of pulp, you can't see through that one at all. So that one's going to be considered a full liquid. Puddings, milk, all of those are going to be on this list. Then we have our soft foods. These are going to be oatmeal-like consistency. Then we have puree. This is pretty much anything you want, just stuck into a blender. So it could be meats that are pureed. It could be vegetables. It can be pretty much anything, just blended up, made mushy. And then we're going to progress all the way to regular foods. Often, I remember a lot of times we're starting off with those clear liquids and then advancing them slowly. We also have diets that are content modification diets. These are for people who have health concerns that require nutritional changes. So cardiac diet is a classic one here. These have to have low fats because fats help clog our arteries. We want low sodium because water follows salt. If we have lots of salt, then we have lots of water circulating in the bloodstreams, placing increased strain on the heart. And then no processed foods because those are usually very high in sodium, fat, and sugar. Renal diets are extremely boring and very just kind of disheartening to eat. Because first, we're going to take out sodium, phosphorus, and potassium, which are all the things that flavor food. So this is all your salts and things that make food taste interesting. We're going to take all that out. And then we have to do a fluid restriction. So we're also going to dehydrate the foods so that they don't have as much fluid in them. So nothing that flavors foods and then nothing that adds fluids. So it's like eating cardboard. And then we're going to limit the protein too. So there's really nothing remotely interesting to eat in a renal diet. It's very, very difficult and demanding. And there's lots of patient education that go into these diets. We also have diabetic diets. We're going to limit sugars. So think sweeteners, fruits, breads, because carbohydrates are a sugar. And then again, especially those processed foods and packaged snacks because they're very high in those sweeteners and sugars. Then we have different types of nutrition we can have. We can have enteral nutrition. So again, this goes through the gut. We always are going to begin with calorie counting. So we are going to ask a dietitian for help. If we suspect that a patient has over or under nutrition, we are going to start off by obtaining a weight, and then we're going to do a calorie count because we want to know if the problem is nutritional or if it is disease related. And then we can provide enteral nutrition via tube feeds, which we'll talk about in a moment. These are designed to give supplemental nutrition whenever the patient isn't taking in enough. And then we can do parenteral nutrition as well. It can either be TPN, so total parenteral nutrition, or PPN, partial parenteral nutrition. When this is given through an IV, we are bypassing the gut entirely. If it is white, this is going to include lipids. Sometimes they're separated out into separate bags. We have amino acids and electrolytes in one bag and lipids in another, or they can be combined into one thing that's just our TPN altogether. And then we are going to think about when we are actually providing supplemental nutrition. So whenever a patient is not able to eat, right? So a patient can go 7 to 10 days without eating before they die from this. We're going to start considering giving supplemental nutrition once they've had inadequate nutrition for 72 hours or 3 days. Then we're going to want to consider supplementing and adding something else on board. If they haven't eaten in a week, we absolutely need to be doing something at that point. We do have several different options. We have NG tubes. These are nasogastric tubes. It is going to go through the nose to the stomach. We could also have an OG, so orogastrics, going through the mouth to the stomach. These have an extremely high aspiration risk. If you think about it, whenever we are normally eating, our epiglottis normally closes and shuts off the airway and opens up the esophagus. If we are putting a tube down, we are preventing the epiglottis from being able to close entirely. Because of that, it's an extremely high aspiration risk. We absolutely need to make sure that we are sitting up the head of the bed to at least 30 degrees during and after feeds to help prevent that. We can also give central parenteral nutrition. That is always going to be through a central line. Central lines can be many different versions. It could be through a PICC, a Mediport, non-tunneled or tunneled. All of them are going to end at the vena cava. That's the distinguishing mark, is that everything ends at the vena cava and then gets delivered to the blood circulation. And then we have more permanent options. This is for when we have patients who need more long-term therapy. We have a PEG tube. This is going to go percutaneous enterogastric. It goes through the skin into the stomach. We do still have an extremely high aspiration risk for these patients. Again, we want to make sure we're sitting up the head of the bed to 30 degrees before, during, and after feeds. PEG tubes are what you can see in this picture at the top here. It's just inserted through the skin, and the tube is always there. There is risk for skin breakdown. We want to make sure we're always assessing the skin around this site as well. And then we do need to consider gastric residual. So gastric residual is how much volume is still in the stomach. Sometimes we need to actually assess whether or not the patient is processing all the nutrition we're giving them. It should be less than or around 200 milliliters. If there is more there, this is a patient who has delayed gastric emptying. We absolutely need to put this back into the stomach, though, or we can cause electrolyte imbalances. We know that patients have stomach acid present, right? And if we have stomach acid and bicarb, that's all part of our pH balance. If we take this away and don't put it back, we're messing up their pH balance. Hang on, guys. I'm just going to pause this for a moment. All right, continuing on talking about our various tubes that we can give. So when we're measuring gastric residual, what we're going to do is we're actually going to take out everything that's in the stomach and we're going to measure it and see how much is in there. Again, we are going to be able to put this back when we're done measuring it. Be very careful with this. It's easier for that tube to come unconnected, especially if they had something thick in there. Make sure you wear appropriate PPE for this procedure to make sure you're not going to accidentally get anything splashed on your face. Again, though, we always put that stomach contents back. Now, if they have too much and we put it back, part of what we need to do is actually put all the residual back in the stomach and then either stop the feeds entirely or slow them down. So we're going to give them a little bit of a break so that they can reabsorb all that because they're having delayed gastric emptying. So we're going to give them a break, let them absorb everything they haven't absorbed yet, and then maybe slow down the feed rate when we restart it so that they can have time to absorb all the nutrients before getting just full. And then we also have gastronomy buttons or G buttons. These are great for kids. We see these a lot in pediatric populations. A lot of times kids have G buttons placed because they need supplemental nutrition for longer periods of time. A lot of times their guts are immature at birth and they just need some supplementation for a little while. And we can do this G button, but kids love to pull on tubes. So one thing we can do is instead of doing a peg tube where the tube is always in place, we'll do a gastronomy button where you can actually disconnect the tube and it's just kind of locks in place. Personally, I ask the parents to unhook and hook these up because they can be kind of tricky to access. And if you don't access it correctly, now you have stomach content spilling everywhere. So I just hand all the equipment to the parents and let them do it because they do this multiple times a day. The nice thing is that you can just connect it and give the meds and the feeds or whatever it is and then unhook when you're done. For adults, we also have what are called Dobhoff tubes. These are very narrow in diameter. The major thing to know with these is that you cannot give meds through a Dobhoff. They will get clogged up. With tubes in general, if they do get clogged, because sometimes that happens if we're giving too much medication, it's not diluted well enough, whatever the case may be. If it gets clogged, we need to unclog it. One thing you can do is try to flush it with warm water. If that doesn't work, we're going to administer pancreatic enzymes per physician order to break up everything in there and kind of digest it. The old school method is to use Coca-Cola. If any of you have ever seen those videos of dropping a corroded coin into Coca-Cola and it becomes clean again, think about that, but to the peg tube or the G tube or whatever it is. Do not do this in practice. You absolutely will get in trouble for that. It is still used in like third world countries and stuff like that in rural situations for getting tubes unclogged. All right. When we think about nutrition and taking action, who are we going to get help from? This is going to be our dietitian. This is going to be our speech therapist and OT. They can always help. And then think about how we evaluate outcomes. We always want to know whether or not our patient is improving in their nutritional status. So we're going to weigh them again. We're going to see if their weight has improved. Are our labs improving? Have we actually achieved what we want to? Those types of things. All right, guys, like I said, this was going to be a short and sweet one. I will post this for you shortly and see you tomorrow in class.